Haematological Emergencies. So I don't know, are there any topics in particular that you're interested in talking about? Or should I just make a choice?
If you want to go ahead, they're very quiet.
Yeah, right. So if we can make this a bit more interactive, can anyone think of any hematological emergencies?
Neutropenic sepsis?
Sorry?
Neutropenic sepsis.
Yeah, so neutropenic sepsis is the commonest one, isn't it? And I think you might have come across that quite frequently in people who are on chemotherapy, either oncology or hematological patients. Anything else you can think of? Anything you came across?
In the chat, someone said sickle cell crisis.
Yes, so sickle cell crisis indeed. Although I think in our trust we don't have that many sickle cell patients, but in some parts of the country, like in London, for example, you would have a big sickle cell population, so it becomes more relevant. But it's important to be aware of the sickle cell crisis. I don't know whether you watched the news a few days ago about a patient who was in one of the northern London hospitals, young man, and he died with chest crisis while in hospital. Okay, anything else?
Some replies in the chat. Can you see that?
So just a selection of the hematological malignancies. Histology, I tend in my mind to sort of divide it into four major categories. So I think about bleeding and thrombosis, and that could be, the bleeding could be because there's a coagulopathy or someone is on anticoagulation, or they have low platelets. So conditions that can cause low platelets like ITP or HIT or TTP or DIC, that sort of thing. And then you have thrombosis, like the massive PEs. So that could be an emergency, life-threatening. And antiphospholipid syndrome can sometimes present as an emergency. And then I think about the white cells, so that's the hematological malignancy or hemato-oncology bit. And there are quite a few things that can cause emergencies. Someone mentioned the neutropenic sepsis. People who first presentation with leukemia, especially the acute leukemias, you can have leukostasis. There is, they can present with spontaneous tumor lysis, or immediately after you start the treatment, they can start to tumor lyse. Hypercalcemia is not an uncommon presentation in hematological malignancy, especially in myeloma and lymphoma, and cord compression. You can see that in a few cases like myeloma, lymphoma. You can see it in extramedullary hematopoiesis sometimes, in people with myeloproliferative neoplasms like CML. Some ET patients can present with that. And some thalassemia patients can have extramedullary hematopoiesis causing cord compression. Right, hyperviscosity can be a presentation as well in people with very high immunoglobulins, like very high paraprotein, especially the IgM paraprotein. So you can have hyperviscosity. Now, the other major category of hematology is the transfusion. And I think transfusion, maybe it's relevant to everyone because you can come across transfusion reactions. And then you've got the massive hemorrhage. And the last category is the red cells. And things that can happen to red cells and cause emergencies are things like intravascular hemolysis, for example, or someone mentioned the sickle emergencies. Polycythemia vera can cause thrombosis, both arterial and venous thrombosis. Right, so I've just chosen a few things to talk about today because this is quite a long list of emergencies. So maybe we'll talk about DIC, tumor lysis, neutropenic sepsis, hypercalcemia, cord compression, transfusion emergencies, and some sickle complications. If we have time, maybe we can mention something about acquired hemophilia. Right. So the first case is a 24-year-old man, previously fit and well. He presented with 3 weeks history of shortness of breath, lethargy, easy bruising, mucosal bleeding. Yeah. And these are his bloods. So he's very anemic with a hemoglobin of 65, platelets of 43, white cell count of 79, and neutrophils of 1.2. So any thoughts? Anyone? Obvious things. So what do you think about the full blood count? No? Right.
A few replies in the chat.
Okay. Let me see the chat.
Leukemia.
Why can't I see the chat? All right. So Anita, what does it say? Leukemia? Yep. So leukemia is yes. So it's and the reason why I guess you said leukemia is because of the high white cell count and the pancytopenia. Right. So what investigations would you do?
Do a blood film. One said.
Yeah. Yeah, so blood film, really important. And that would actually, the blood film will be triggered by the lab. So someone who's not known to hematology with this full blood count will automatically be triggered for a blood film, and the biomedical scientist will have a look at the film and then alert the hematologist or the team to the findings within the blood film. So
bone marrow biopsy.
So before the bone marrow biopsy, let's have a look at the blood film. So this is the blood film. What do you think? You can also unmute yourself and right. So the blood film shows these big immature looking cells, white blood cells. And they've got high nuclear cytoplasmic ratio. The nucleus looks a bit bilobed in some of these cells, and then they have all of these rod-like structures, isn't it? Yeah. So this blood film, does anyone know what this is? No? Any clues? Right, so this is typical of a type of acute myeloid leukemia called acute promyelocytic leukemia, APL or APML. Yeah, so APML is a hematological emergency, and the reason why it is an emergency is because typically APML can present with coagulopathy. So you've got these immature promyelocytes, and they release all of these procoagulant substances into the blood and activate the coagulation system. So you've got a DIC-like condition where you have activation of the coagulation and the fibrinolysis system. So you've got consumption of the clotting factors, consumption of the platelets and the fibrinogen, and then people tend to bleed. So the mortality rate could be high initially if not treated, and it's mainly because of bleeding. But if you manage it appropriately and get them through the initial phase and then treat the leukemia, it has a very good overall prognosis in terms of the survival, which is about sort of 80–90% of people will be cured. So you need to recognize this and you need to treat it urgently. So if I get called during the night about someone with query APML, they will need to start the treatment that night. I will not wait until the morning. And so these are the clotting profile for this patient. So they've got prolonged PT, they've got prolonged APTT, and reduced and low fibrinogen. So how do you manage this patient? Right, so that's how I would manage this patient. So I would correct the clotting, and there is very strict criteria in terms of what to maintain the clotting at. So you would give them fresh frozen plasma to maintain their INR and APTTR less than 1.5, and you would give them cryoprecipitate to get the fibrinogen above 1.5 and maintain it above that level, and you would maintain the platelets above 50, and you would keep checking. So if I have a patient with APML, I would check his bloods twice a day and give them products as required. Of course, anyone who presents with an acute leukemia, you would be concerned about infection as well, because they don't have a competent immune system. So you would have low threshold for looking for infections and starting them on antibiotics. You would be concerned, especially in people with high white cell count, of tumor lysis. So you would check their tumor lysis bloods. Does anyone know what tumor lysis bloods are? Right, so if I ask someone to do tumor lysis bloods, what I mean is their renal function, their calcium level, their phosphate, and their uric acid, urate, LDH. Yeah. So I would check their tumor lysis bloods, and I will start them on allopurinol at least, and fluids. And then for APML in particular, I would start all trans retinoic acid. even before the diagnosis is confirmed. And the diagnosis it can be confirmed by either sending the peripheral blood for the translocation 1517 by FISH, or doing bone marrow urgently. So before, but even if you just suspected, before even confirming the diagnosis, I would start them on ATRA and then subsequent chemotherapy once it's confirmed. All right, so this is a special case of DIC caused by APML. The other causes of DIC, there are multiple causes of DIC. So all sorts of things can cause it, like infection, trauma, pancreatitis, amniotic fluid embolism, malignancy, etc., etc. And in other DIC can be acute or chronic. And in the other causes of DIC, we tend not to treat the blood results. So you treat the underlying cause, and you monitor the coagulopathy. You only treat it or correct it if they're bleeding. Yeah, so that's a distinction between DIC caused by APML and the DIC caused by other causes. So you only treat or correct the abnormalities if they're bleeding. Yeah. Right, so the other thing that we touched on in the previous case is tumor lysis syndrome. So tumor lysis syndrome can happen spontaneously even before we start treatment, or it can happen soon after we start treatment. And even steroids can cause tumor lysis. So we can see when you have a patient with a hematological malignancy, be it acute leukemia or lymphoma, you would have to risk stratify them in terms of the risk of developing tumor lysis. If they're high risk, and there is criteria to help you define which ones are the high risk. So these are the bulky lymphomas with high LDH, or the leukemias with leukocytosis more than 100, or people with renal impairment, etc. So the high risk people, you would give them fluids and rasburicase. The dose of rasburicase depends on whether they have evidence of clinical or lab tumor lysis syndrome, or you're just using it prophylactically. If they're low risk, you can use allopurinol plus fluids. Yeah. And then you monitor as well. So you have to monitor. What's important about tumor lysis is that the abnormalities, the calcium. So you would expect if people are tumor lysing, their calcium will go down because it sort of combines with phosphate, and then it precipitates in the kidneys. Urate precipitates in the kidneys as well, causing renal impairment. So you would expect the calcium to go down, but the other indices will go up. The urate, LDH, potassium, phosphate, creatinine, they will go up. What's important to know is if the calcium is down, if you don't correct it, if they're asymptomatic, because you will just propagate the cycle. And then you would address the hyperkalemia as you would with other patients with hyperkalemia. You do what you do normally with the insulin, glucose, and salbutamol nebulizers, and then dialysis if needed, or hemofiltration. Right, so I think that's about tumor lysis. Does anyone have any questions so far about what we talked about? in case 1. So we talked about BIC and tumor lysis. Anyone? Anything? I'm not sure. I'm
No comments in the chat.
No?
No.
Right. So, but feel free to stop me and ask questions and ask for clarifications, etc. Yeah, it's very hard to do like a monologue and not get feedback. Right. So let's move on to case 2. So case 2, you've got a 59-year-old woman. She was recently admitted with anemia, hemoglobin of 47, EGFR of 28, and she was complaining of back pain. She was transfused and discharged. She represented with a hemoglobin of 37, EGFR of 24. Her full blood count was otherwise normal. The blood showed total protein of 130, so that's high. Her albumin was low and her calcium was high of 3. You did a X-ray and that showed osteopenic thoracic wedge fracture. So what are you concerned about in this case? And what do you think we're talking about here in terms of hematological malignancies?
Multiple myeloma, cord compression.
Yeah, that's right. Yeah. So, yeah, that's right. So we're concerned about multiple myeloma, and what makes you suspect multiple myeloma is the high total protein, even though the albumin is low. So it's probably the globulin component, isn't it? So it's probably someone with a high paraprotein. Also, they're hypercalcemic and they've got back pain and they're anemic and they've got renal impairment. So all the classical symptoms and signs of multiple myeloma. Yeah. So someone with back pain with multiple myeloma, you would have to think about cord compression. So you will have to do a neurological examination, ask about their sort of bowels and passing water, that sort of thing. So cord compression, you would find it in about sort of 3 to 5% of people with malignancy, and you would have a sensory level. You could have paresthesia. By the time you have sort of motor impairment, it's sort of might be a bit too late. And then you ask they will have sphincter disturbance if it's coda equina and saddle paresthesia, that type of thing. And the way there is a trust pathway to dealing with cord compression, and you should be able to find it on the intranet. I think it's under acute oncology guidelines. And I just took a screenshot. So this is what it looks like. So it tells you exactly what to do and who to contact. With the bleep number of the oncology SPR in Brighton and how to contact them. So basically, what you need to do if you're suspecting cord compression is to get an urgent MRI spine. And in multiple myeloma, we image the whole spine because there could be multi-level problem, not just area where the pain is localized to. So whole spine MRI urgently. If they've got neurological symptoms or signs, you start them on steroids, and usually we start them on dexamethasone, 8 milligrams BD. We talk to the oncologists about urgent radiotherapy if it's a soft tissue component, and if it's a bony component, we talk to the neurosurgeons. Usually we do both. So we refer them urgently to the neurosurgeons and the oncologist at the same time, because the neurosurgeons might need to do stuff like stabilization of the spine or decompression. There is a referral. Do you know how to refer to the neurosurgeons? So there is a web interface, referapatient.org, and you make the referral there, and then they will get back to you urgently. Yeah. All right. Now, so this is cord compression. Any questions at all? I think what's important about cord compression is to suspect it in the first place, and then knowing what to do in the initial phases and who to contact and how to contact them. Yeah. Now, the other emergency related to this case is hypercalcemia. So hypercalcemia, you can see it in people with myeloma, 30% of patients with myeloma. You can also see it with people with lymphoma. And you can they can present with symptoms of sign of hypercalcemia, where they have like polyuria, polydipsia, fatigue, constipation, bone pain, confusion, arrhythmia, renal failure, etc. So you should be able to deal with hypercalcemia. So it's like you give them fluids, and if they're overloaded, you can use loop diuretics and bisphosphonate. Depending on their renal function, you can either give them Zometa, that's what we usually use for myeloma patients, or pamidronate if they've got renal impairment, because you can reduce the dose of the pamidronate, like 30 milligrams. And then if you're not if you're not winning with these measures, and you're running into problems with overload or people with CCF, etc., you can always consider dialysis. There are other treatments for hypercalcemia, especially refractory hypercalcemia, that don't respond to the fluids and bisphosphonate. We can use calcitonin or denosumab, which is used in oncology patients. And sometimes steroids help. Yeah. Right. So multiple myeloma, this is what it looks like. So all of these cells, the blue ones, these are plasma cells within the bone marrow. It's very rare to find plasma cells in the peripheral blood, except in plasma cell leukemia. So this is a bone marrow, and this is a high sort of excess of plasma cells, and you can find sort of lytic lesions in the bones, etc. The classical sort of descriptions. Right. So myeloma can present with a few emergencies. We talked about cord compression. We talked about hypercalcemia, renal impairment. People sometimes can present with renal impairment, especially people with high serum free light chains in the thousands, and people can present with life-threatening infections. Actually, 10% of myeloma patients die within the first 3 to 6 months because of infections. So infection is a major thing. And there are multiple causes of renal impairment in myeloma. I don't think we need to go into. Right, so the next one, neutropenic sepsis. I expect everyone would know what to do with neutropenic sepsis. So it's anyone with symptoms or signs of infection with a neutrophil count or expected to have a neutrophil count less than 1, i.e. people with known bone marrow failure, for example, or people who had recent chemotherapy. The most important thing really is resuscitation and to get the broad spectrum antibiotics into them as soon as possible. When you assess your patients, you just follow your ABCD approach in the ALS guidelines. But it's important just to remember that people with neutropenic sepsis sometimes can present without fever, especially if they're on steroids, etc. And people who are neutropenic and they come in with sepsis when they're hypotensive, I always think about gram-negative organisms, and I would give them a shot of gentamicin to cover for that. But if they're hemodynamically stable, I wouldn't give them gentamicin, especially the myeloma patients, because of the potential renal impairment with that. But there is a trust guideline. So again, you can find it in the intranet. If you just if you Google neutropenic sepsis or go into the clinical guidelines. So it tells you what to do. Right. Now, next case. We've got, any questions so far? Sorry. All right, so let's move on. Next case. So we've got a 18-year-old girl. She is known to have sickle cell disease, admitted with abdominal pain. Her hemoglobin is 69. Her baseline is 78. So in someone with sickle cell disease, you don't expect them to have normal hemoglobin, but it's important to compare their current hemoglobin to their baseline hemoglobin. And so you might ask, how do I know what their baseline is? So I would get in touch. If you're not in a if you don't work in a tertiary center like hemoglobinopathy center, I would get in touch with their the center where they're registered, because all the sickle cell thalassemia patients should be registered with the hemoglobinopathy center. Yeah. So I would get in touch with their hospital and find out what their care plan is. Every sickle cell patient should have a care plan. It will tell you what their baseline hemoglobin is, what the reticulocyte count is, what their oxygen saturation is when they're well, because this information is useful when they present unwell, because you can compare it against. Yeah. It will also, the care plan will also tell you what analgesia to give and how much to give. Yeah. And it will tell you something about the complications they had in the past. For example, people who had acute chest crisis in the past, they're more likely to develop acute chest crisis again, to have recurrence. So it's really useful to get the background information. But what's important about someone with sickle cell presenting with an acute crisis is you have to deal with the pain. And I think the commonest mistake that junior doctors do when dealing with sickle cell patients is that they don't give them adequate analgesia. So you have to give them analgesia. Usually it's a strong analgesia, opiates, and you don't just give it and go and don't come back. You have to assess their control, the pain control, after 30 minutes. So you come back after 30 minutes, check what their pain score is, and you also want to check that they're not they don't have like over analgesia, as in if they have respiratory suppression, etc., or they're becoming drowsy. You don't want that to happen, because that could make things worse in terms of the hypoxia, etc. Also, it's important with someone with sickle cell disease who present in acute crisis to actively look for infection. Because what are the things that precipitate sickle cell crisis? So infection is a major thing, so you have to actively look for it and cover it with antibiotics, and you usually cover for atypical infections. And you have to keep them hydrated, because dehydration can cause sickle cell crisis, so give them adequate hydration. The only thing is, in children, you should be mindful, they can get overloaded quite quickly. You have to keep them well oxygenated, because hypoxia is also a trigger, yeah, and keep them sort of cold can precipitate sickle cell crisis, and psychological stress can precipitate it. So all of these things you have to look for and correct. So fluids, oxygen, antibiotics if needed with atypical cover, analgesia, very important, especially someone with chest or back pain. You want to give them analgesia, because if you don't, they tend to hypoventilate, and because they don't want to expand their chest, it's too painful, so there's splinting effect, so that makes the hypoxia worse, and that makes the sickling worse, and then they go into like a spiral. So you want adequate analgesia, you want them to keep taking deep breaths, and the way we do that is by asking them to use incentive spirometry. So incentive spirometry is just like a plastic device that you ask them to blow into, that keeps their lung expanded. And oxygen if needed. Of course, with sickle cell patients, you have to be mindful that they have a high risk of thrombosis because of for all of these sort of inflammatory processes happening. So you have to give them thromboprophylaxis. Yeah. All right. So back to the case, 18-year-old, sickle cell disease, abdominal pain. Her hemoglobin is about sort of 1 gram less than her baseline. Now, so you have to think laterally as well. So not everything that sickle cell patients present with is related to sickle cell. So you have to think, is there another cause of the abdominal pain, because they can have the same diseases as everyone else. So you would think about sickle-related and non-sickle-related problems. Of course, gallstones is a chronic complication of sickle cell disease. Right. So at this level of hemoglobin, if just a painful crisis and complicated painful crisis, I wouldn't transfuse them, because in sickle cell patients we try not to expose them to lots of blood transfusions because they tend to form antibodies, red cell antibodies, more so than the average patient, and that's just again because of the inflammation. So yeah, we talked about this hydration, analgesia, infection. Yeah. All right. So this lady, the next day, she developed chest pain. She dropped her saturations to 88% on room air. So it's important monitoring in sickle cell patients. You would ask the nurses if they drop their oxygen saturation by 3. So, for example, if they go from 96 to 93, they should alert the doctors, because that could signify an impending chest crisis. So she dropped her sats. When you come and assess her, you have to do a chest x-ray. Any new infiltrate on the chest x-ray, this is sort of chest crisis. And she dropped her hemoglobin to 55, so she's probably sickling in her lung and hemolyzing. Right, so the other things that you would think about in sickle cell patients in this case is, did they develop PE, for example? Yeah. So what would I do? I would transfuse her. So I would give her a top-up transfusion. Important to be mindful not to over-transfuse sickle cell patients. So I would aim for 10 rather than a normal hemoglobin level. And the reason is, if you over-transfuse them, you would cause hyperviscosity, and you would increase their risk of thrombosis. Now, so oxygen, you would give them top-up transfusion, antibiotics, incentive spirometry, etc., and watch them really, really carefully, because if they don't improve on these measures, you probably need to do an exchange transfusion. Not you personally, but for this patient, you would have got in contact with the hematologist from the beginning, really, and they would be guiding the management. So, so this patient, if she doesn't improve with these measures, she would require an exchange transfusion. That's usually done by the hematologist. Right, so 6 days later, she had a repeat full blood count. Her hemoglobin is 43. Yeah, so you topped her up. She's stabilized, still in hospital because she's still in pain, and you're managing that with opiates. And 6 days later, she dropped her hemoglobin to 43, and she has dark urine, and she's jaundiced. So what do you think is happening? So she dropped her hemoglobin to a lower level than her pre-transfusion level. So that makes you think of a complication. It's a rare complication, but it's a serious one. It's called hyperhemolysis. So hyperhemolysis is when the patient would destroy the transfused red blood cells as well as their own red blood cells. Yeah. So it's a known complication in sickle cell disease in particular. And hyperhemolysis is a big problem because we can't transfuse them because that will make it worse. So we try to get around it by doing all sorts of things, by giving them IVIG, giving them steroids, optimizing their hematinics with B12, folate, and giving them erythropoietin. So we tend not to transfuse them if we can help it. Yeah. So it's a serious complication. Right. So this is sickle cell disease. There are some other complications of sickle cell disease. So apart from chest syndrome, sickle cell patients are 10 times at risk of having strokes, so 10 times more than the general population. They can also present with priapism, so you have to involve urology. And children, they can have sequestration crisis, and people can have aplastic crisis, etc. So that's sickle cell. Does anyone have any questions? In terms of thalassemia emergencies, you would also involve the hematologist very early on, because it's a very sort of specialized area, thalassemia. But things that they can present with as an emergency, as I said, they can have extramedullary hematopoiesis causing cord compression in those who are not adequately transfused. Because thalassemia major patients, they would be on regular transfusion to suppress their own ineffective hematopoiesis. So if they're not adequately transfused, for example, someone who came to the country and is not under hematologist yet, for example, they can present with extramedullary hematopoiesis causing compression symptoms. People who are regularly transfused and are not adequately chelated with iron chelation, they can have all sorts of complications like cardiac failure, for example, arrhythmias. They can have liver cirrhosis. They can have sort of liver cancer, etc. So all of these things we have to think about in thalassemia patients. There are some types of bacteria like Yersinia, for example, in people who are on iron chelation. So that's why you really need to get advice from hematology. Yeah. Right, so let's move on. So transfusion, major hemorrhage. So major hemorrhage, there is a trust guideline protocol. You just follow that. So the definition of major hemorrhage is someone who's lost their total blood volume within 24 hours, and you would expect a 70 kilogram adult male to have about 5 liters of blood. So that's one definition. Another definition, if they lose about 50% of their total blood volume within 3 hours or less, or if they have ongoing blood loss of 150 mils. What did I want to say? Sorry. Yeah. So, but these are not very practical definitions, because if someone is bleeding in front of you, you wouldn't know exactly how much they're losing, etc., and you wouldn't wait 3 hours or indeed 24 hours to find out. So a more pragmatic definition is someone who's bleeding and they're dropping their blood pressure to 90 systolic or below, or they're tachycardic with a heart rate of 110 and they're actively bleeding. So you would trigger the major hemorrhage protocol, and this is what is in your guidelines. So it tells you to call 2222, and you have to explicitly state that you're triggering the massive hemorrhage protocol. You have to say where you are, and the patient's then they fast leave the lab for you. Now, in all the sort of the crash teams, they should have a communication person responsible for the communication. So they will talk to the lab and coordinate with the blood transfusion lab. It will be really helpful for blood transfusion lab to have your the number they can call you back on. And these are the extensions and the lead numbers for the massive hemorrhage. And then you use the, if you don't have time to wait for the group-specific blood or the cross-match blood, so you expect the group-specific blood to be available within 10 to 15 minutes, and the cross-match blood to be available within 30 to 45 minutes. If you can't wait for that, you can use the O negative blood. You can use O positive blood for males and women above the age of 50. Do you know why you can use O positive blood in these patients instead of O negative? No?
Someone said male.
Yeah, so male, yeah, so male and women above the age of 50, because the problem with using Rh positive blood, O positive blood in someone who's Rh negative is that they may develop antibodies in the future. Yeah. So, and that if they get exposed to Rh positive blood again in the future, they might have a delayed transfusion reaction. Yeah. Women within sort of reproductive age, because they might get pregnant, we don't want that complication to happen. But in males, the chances of them getting another Rh positive blood in the future are very slim, and even if they do, it's a delayed hemolytic reactions, which is not generally life-threatening. Yeah, so potentially you can use O positive blood, but anyway, so you would use the O negative or positive blood, and usually it's sort of available, and then you have to tell from the blood bank, you have to tell them you've used it. They issue you your massive hemorrhage pack, and that contains red cells, fresh frozen plasma, and platelets. Yeah. Now, why do we use fresh frozen plasma? So there is a coagulopathy associated with major hemorrhage. And the reason why we use fresh frozen plasma very early on, that came from the military actually. Some studies from the military, they found that they have a better survival. But the reason why is because with massive hemorrhage, there is a coagulopathy. And because when you replace just red blood cells, they don't have clotting factors. So, and you would have started them on IV fluids anyway while you're waiting for the bloods for volume expansion, etc. So there will be like a dilutional coagulopathy associated with major hemorrhage. Also in trauma patients, there is an acute traumatic coagulopathy because there's activation of the clotting system with all of these sort of tissue factors and blood exposed to sort of tissue factors, sorry. So there will be activation of the clotting cascade as well as the fibrinolysis and consumption of these factors. So there will be like a DIC type of picture. So you want to replace the clotting factors and the fibrinogen. Also, if you give lots of products with citrate, you will take out the calcium. So you will chelate the calcium, and hypocalcemia is associated with coagulopathy, also acidosis. It's also associated with coagulopathy and hypothermia. So there are a few reasons why people would have problems with their clotting when they're bleeding. That's why we replace the FFP quite early on, and the platelets. And the platelets, you keep them above 75 unless they have multiple trauma or CNS bleeding into the central nervous system, or if they have problems with their platelet function. Yeah, you can keep it higher, around 100. Right, so you just follow the protocol, really. You communicate with the lab, and that's it. Now, and you have to monitor. Important thing is you keep monitoring, and your clotting test will guide you in terms of further replacement, and you're again aiming to keep the PT and APTT less than 1.5, fibrinogen more than 1.5. Yeah, and then you don't rely on the hemoglobin level initially, because it takes time for the actual hemoglobin level to reveal itself with the volume expansion, etc. Right, so this is major hemorrhage. Now, we might be running out of time, but the next case is about transfusion reactions. So someone is having a blood transfusion and suddenly they develop symptoms. So transfusion reactions can present with several things like dyspnea, hypotension, tachycardia, hypertension, wheeze, angioedema, urticaria, itching, nausea, abdominal pain, back pain. Some people describe a sense of impending doom, especially those who are receiving incompatible ABO blood. So the complications of transfusion. What do you do when you have someone who becomes acutely unwell while receiving a blood transfusion? The first thing you do is you stop the transfusion and you assess the patient, you stabilize the patient. So your priority is the patient, is not to investigate the cause of the sort of, is it blood transfusion and what type of reaction is the patient having. So you do your ABC, you stabilize the patient. Now, if the patient has circulatory, if they're unstable, or if there is sorry, let me backtrack. So you stabilize the patient, you stop the transfusion, you check the patient's ID against the compatibility tag in the blood product. Yeah, and you visibly inspect the unit as well. So if it's an incompatible blood, if the unit looks damaged or there's a precipitate in it, or if the patient's hemodynamically unstable, this is a severe transfusion reaction. Now, there are mild and moderate transfusion reactions. Some people can develop a fever. If it's less than 2 degrees from their baseline, this is a mild transfusion reaction. You can allow for sort of itching or rash with it. But if there is any other symptoms, or if the rise in temperature is more than 2 degrees or more than 39 degrees Celsius, this is a moderate transfusion reaction. Then what you need to do is to assess whether what's happening to the patient is because of the transfusion, or is it because of the underlying condition. For example, someone might be septic and receiving blood transfusions, and they've been spiking temperatures the whole day. If they have a temperature while they're having the transfusion, that could be because they're infected to start with. Yeah, so you have to think, is this a transfusion, or is what's happening is consistent with the underlying condition of the patient. Now, if it's moderate and you think it's related to the transfusion, or if it's a severe transfusion reaction, then you would have to do extra things. Yeah. So if sort of patient is stable, etc. If you would have to you would return the transfusion, the unit to the blood bank along with the giving set. Yeah, so don't discard it. Return it to the transfusion lab. From the patients, you take a few. You have to report this, and you have to take a few bloods. So you take a full blood count, because they can hemolyze, for example, if they are ABO incompatible blood, so they will drop their hemoglobin. You would check their renal function, because intravascular hemolysis can cause renal impairment. You would check their liver function test, because their bilirubin might rise. You would do a clotting screen, including fibrinogen, because with BIC, you can find the abnormalities in the clotting screen. You would take blood cultures if they have fever, and you would take samples for DAT, direct Coombs test, LDH, and we talked about blood culture. And then you would tell the lab, and then the lab, they will do several things. They will send the unit back to the National Transfusion Service, where they might need to recall the associated units. So if it's the same, if they've fractionated the blood into several components or units from the same donation, they might need to recall the other blood components from hospitals around the country, etc. They will need to report it to SHOT, which is the serious hazards of transfusion. And all of this data is collated and then interrogated to see how we can improve the safety of blood transfusion, etc. So in terms of reactions of blood transfusion, what could happen? So when we think about them in terms of acute transfusion reactions and delayed transfusion reactions. If it's within 24 hours, this is an acute reaction. Delayed more than 24 hours. And acute transfusion reactions could be febrile non-hemolytic transfusion reactions, could be hemolytic transfusion reactions, could be anaphylaxis or allergic reactions, could be bacterial contamination, especially with platelets, because they are stored at room temperature, and could be transfusion-associated circulatory overload, TACO, or TRALI, which is transfusion acute lung injury, transfusion-related acute lung injury. So all of these things could lead to an acute reaction, and it's not always easy to sort of tease out which one it is. That's why it's important to treat the patient, so stabilize the patient, and then the investigations will be done. later on. Okay, right. So the delayed ones or chronic morbidities, you don't need to worry about. And I think that's it, and we just ran out of time. But if there are any questions, I'll be happy to answer. Or if there's anything else that you wanted me to talk about, I can include that in future sessions, etc. I'm happy to be emailed about any questions or queries as well. Yeah.
Thank you.
All right. Thank you. All right. So if no questions, we can end the session. Thanks.
Everyone's saying thank you.
Thanks.